growth hormone replacement therapy. When they ask you questions about this particular disease, it's usually about the medication. And it is a sub-Q injection. It can be weekly and it can be daily, depending on the brand. So don't overthink this. But what's important is that it's given at night. We have to rotate the sites of the sub-Q injection, just like if they're getting insulin, just like if they're getting other kinds of sub-Q medications, we got to rotate sites. We give it at night. I'm going to ask you guys, why do we give this medication at night? Why do you think this hormone should be given at nighttime? Anyone? When do kids grow like normal kids?
It's quiet as hell. Everyone got dead be quiet.
Erica, when do kids grow? Thank you, Michael. Yes, kids grow at night. They do. They grow spurt at night. So therefore, we give, exactly, most hormones are secreted at night for growth. And so therefore, we give this injection right before bedtime. Because this is when this particular hormone is typically secreted during the night. Is this medication given forever? Or do we stop at some point? Do we stop giving the med? Or do we give this medication? Right. So we cannot give this medication forever, or we're going to end up with hyperpituitarism. We stop giving it when the growth plates are finished growing. Typically around usually when they're teenagers, when they hit puberty, and a few years into that. So we usually just measure growth plate. We have to teach the parent that this kid is not going to be like super tall. That's not the purpose of this medication. They're going to be at some height that is average to the family, because that is what normal growth for them is. Okay? That's what we do with this medication. So please understand how growth hormone replacement therapy works, that it is not a forever drug. You cannot give it forever. That it will end, and this child is not meant to be super tall. We're not making a basketball player. We're just trying to get him to average familial height, whatever that might be. It's going to be different for each kid. Okay. I hope if there's questions on it, please ask. But that's hypopituitarism. So let's go into hyperpituitarism, which is an increased secretion of growth hormone, also called acromegaly or gigantism. We do have basketball players and football players that have acromegaly or gigantism. There was quite a few actors, also wrestlers, that have this particular problem. And how do we know this diagnostically? Well, lab work, we're going to go look at growth hormone levels. On imaging, we're looking at cardiac and musculoskeletal issues. But sometimes this acromegaly and gigantism isn't like truly figured out or caught until they continue to grow, and it's unusually a lot of growth. Them as children should grow relatively normal as other children. I mean, some do grow very quickly. Now, if we have a baby, if we have an infant that is growing unusually fast and is like shooting off the growth chart, they're going to be in the 90th. They're not a failure to threat. They're like in the 90th or over percentile. If they have large babies in the family, and this is a normal familial thing, then we're not going to overthink them, okay? But if this baby is large, like overly unusually large, and growing unusually fast for a baby or a toddler to an average-sized family, then we're going to go see if we have like increased growth hormone levels, because the pituitary gland could have a tumor on it or a cyst or something that's making it hypersecrete, and so showing up more rapidly, or it's manifesting a little later where the pituitary gland, there's nothing wrong with in childhood, but after puberty it continues to secrete, because the pituitary gland itself should stop secreting at some point in a natural sense, like we stop growing. During puberty, there's a certain part where we stop growing, and that's usually around the age of 17, 18 years old, depending on if it's male or female. Girls grow taller sooner and stop growing taller. They stop growing sooner also. Males tend to growth spurt a little later in life when they hit puberty, because they hit puberty a little later. But they also then have the span of where they stop growing at some point. So there could be like two subtle issues at hand, where the pituitary gland just doesn't stop secreting when it's supposed to stop, or there's a tumor on the gland when they're like in younger, and then now they're like huge babies. Okay, so we're going to do imaging, and we're going to look for this tumor or something with this pituitary gland. But why cardiac musculoskeletal and we're going to look at growth plates, but the heart is highly taxed when they grow too big, too fast, and it makes the heart muscle like hypertrophy. So sometimes they'll have cardiac issues. These clients that have a hyperpituitarism that is untreated, they die young, because gravity takes a hold, their bones can't keep up, their heart can't keep up with the circulation, their body gets too big, and gravity and the hypertrophy of the heart will eventually kill them. So we have to understand that this needs to be treated in a way. So nursing consideration-wise and therapy is removal of the offending item. If there's a tumor, then we'll have to remove it. It could be surgical, it could be chemo, it could be radiation. And our nursing considerations are about pre and post surgery or about radiation care. That's really it. So make sure to review and look at pre and post surgery for nursing. And that's where some of the development comes in when we're talking about what age is the growth hormone, or what age is the hyperpituitarism is caught, and that's in the general sense, that's basically it. It's not overly complicated here. Okay. Any questions on hypo and hyperpituitarism? Not crazy? It's not crazy. Promise it's not crazy. Not crazy stuff. All right. Let's go look at precocious puberty. I got an interactive video, so be ready to chat a little. Here we go.
I'm here at Stanford Medical School with Morgan Thies and Dr. Laura Backrack, and they're going to teach us some things.
Okay, so what are we going to learn about today?
I'd like to talk about precocious puberty.
Did your mom go to the store and pick up the thing that she was supposed to pick up?
All right, what do you guys know about what is precocious puberty to you? What do you think it is?
She might have put it downstairs. Maybe. Because that's where they would be.
What do you guys think? What is precocious? Okay, good. It's sounds like it's early puberty. They're precocious. It basically is. When do you think early is too early? What age do you think is too early to you? All right. Very good. It is before age 8. So for those of you that work in the ER and we have to take a patient to get an x-ray, when do we run? What age do we start running the HCG, the pregnancy test, the urine pregnancy test? When do we start running those? Anybody know their policy? At what age do we start running urine pregnancy tests? We have a step. Oh, once they start menstruating. But do they know? But do they know? So in reality, we actually should, well, policy-wise, it should state that we run urine HCG tests in females starting at age 8. Not that we think that it's just the potential that they could have started puberty at age 8, and therefore we need to start checking unfortunately, we run that test starting at age 8. For everybody. I mean, for females across the board. Just because their puberty can start at that time, unfortunately, they can easily, it's a possibility they could be pregnant.
Seems to be on the mind of many parents these days. They worry that their child is developing too early. They worry their child's going to be too small as a result. They worry their child's going to get picked on. And they worry they might have done something wrong, fed the child the wrong food or exposed them to the wrong videos to cause this all to happen.
Okay, so could we just talk about what precocious puberty means? It almost sounds like they've done something too soon. Is that correct?
Well, it's exactly true. The normal process of puberty in a girl, we used to think, started around the age of 10 with a little bit of breast development. And about 6 months later, the girls would get a little bit of pubic hair, and around the age of 12 3/4 to 13, they'd get their first period.
Okay.
In boys, we used to think the process was starting a little later at about 11 and a half. The boys would get some enlargement of the testes. They'd get some pubic hair about a year later, and by age 15 or so, they'd be mature. We have a definition of what's precocious when there's signs of puberty before 8 in a girl.
Okay.
Or before 9 in a boy.
Okay. So 8 or less.
Less than 8 in a girl
would be precocious, and that's for the breast development, which happens first.
Any sign of puberty.
Okay.
The breasts, the pubic hair, or the periods would be precocious if it happened before the age of 8 in a girl.
Okay, so any sign of puberty, don't worry, we already said it was age 8. So again, any sign of puberty before age 8 is a sign of precocious puberty. Now, these are children. Can you imagine trying to explain this to a child, that what a period is? 8-year-olds, these little kids, they're young. And parents do worry about many things. What kind of things have you guys heard of that could cause that, was on the media, in the news, or whatever, that can cause problems with precocious puberty? Have you heard of any of these things? They were floating around for a little while, and then kind of died down because there's other things in the news. A lot of parents worry about food, what they're giving their kids, or what children are ingesting these days, especially hormone-wise, with milk products and certain kinds of processed foods or soy. It's just a concern, of course. Here, we're not trying to prevent it in a way. We're not really talking about that when we're talking about precocious puberty. We're really looking at how to solve the issue because we've caught it and they've started, and now what do we do with it? But there are things.
And in a boy, before the age of 9.
Okay, John.
Now, this has become a little bit controversial because there was one very large pediatric study that involved over 17,000 girls that found that as many as 25% of African American girls would have a sign of puberty before 8, and as many as 7% of the white girls had some signs of puberty before age 8. But we're still basically using these guidelines, not to say this is definitely abnormal, but this is something we're going to evaluate if we see signs of puberty before those age landmarks.
Okay, so it sounds like there's a lot of variability. It's kind of hard to know on any individual case whether it's normal or not, but we have to have some kind of threshold for which we're going to work someone up, make sure that everything's normal.
You hit on a really important word, and that is variability. And a lot of this variability is determined by genetics.
Okay.
So part of what we always need to know is the timing of development in the family. So when did mom get her first menstrual period? When did dad get his puberty and growth spurt? So that's part of it, is genetics, and we need to know that, take that into account. If mom had her first period at 10 and started her breasts at 8, it may be perfectly normal for her daughter. If mom's periods were at 14 and her daughter has breast development at 7.5, it's more worrisome. Okay, the second factor that seems to be contributing potentially is the overnutrition of our young people. And in the particular study that I mentioned to you, where they looked at over 17,000 children, at least for the white population, they could explain the earlier signs of puberty as an association with a high body mass index. So it looked as if you overnourish your child, you may speed along their growth and eventually potentially speed along their onset of puberty.
I see.
So do you guys think overnutrition can increase onset of puberty? Is that a yes or a no? Can it? And overnutrition cause in early puberty. Think about this. Yeah, good job. So when you think of children, think of the gymnastics kids. Those girls that do gymnastics. Or the female athlete. I think I mentioned female athlete triad, like when we were talking about asthma. But you're correct. When we have little ones that over exercise, like they're in gymnastics or they're in cheerleading or they're in sports, like, well, we know in girls that this is an issue, or in boys where they have a lot of, boys can be affected by this too. They actually can, with the overnutrition part, or undernutrition. I'm so sorry, I meant undernutrition. So, with that being said, they have amenorrhea. They don't have menses. They don't have enough body fat on them. These kids don't have enough body fat, and so therefore don't have puberty. They have delayed puberty. That's not precocious. That's like delayed onset of puberty, or they stop puberty because the body thinks that you don't have enough fat. You cannot support a growing human being inside of you. Therefore, I'm not going to even let you. So we're not going to have periods. So the opposite is true. Overnutrition can influence puberty. The body is fully nourished, has lots of extra stores, and they're like, oh, we can, not all the bodies, but a lot of the body will say, oh, we have a lot of extra storage here. I mean, we have a lot of extra nutrition. We could totally support another human being. I mean, this is very basic. So we can support another human being growth in our body, no matter what age it is. We're tall enough, we're big enough, we have enough caloric storage. Let's start puberty. So it can influence puberty in that sense. It totally can. So what does that mean for us is that balanced nutrition is extremely important in pediatrics. This is what that means.
Now, this did not hold up as an association in the African American population.
Now, that's not what it's saying is it's not 100%. This is certain body types. In certain populations, it doesn't make a difference. Okay? It's just one variability that can happen. It's not 100% if this child is overweight and has all these things, it's not 100% that they're going to start this precocious puberty. That doesn't mean that, but it is one variable.
So there's
that
other factors going on there. But that's something that we take into account. But the bottom line is the child may present with some signs of early puberty. Mom or dad get worried, they go to the pediatrician, and the pediatrician has to decide what's going on.
Okay, now, just backing up a little bit, is this a problem? I mean, what's the problem with, say, a 7-year-old girl starting puberty? What are we going to say, like an 8-year-old boy starting puberty early? I imagine there could be some social implications, as you mentioned, but what are sort of the things we worry about?
Well, that's an important question because it comes up not only how far do we go to evaluate them, but how far do we go to treat them. So one of the concerns parents have relates to their final height.
Okay.
So if they start their growth spurt early in life and close it off early in life, are they going to cheat themselves out of some final height?
Right.
So height is a concern. Okay. And its impact really depends upon how young the child is. A 3-year-old going into puberty is definitely going to end up short if we don't do something.
Okay.
A 7.5-year-old girl is probably not going to be altered by this in terms of height. A second concern is definitely what you brought up in terms of a social concern. Parents worry the child may behave in an older way or may be treated in a way that they're not quite ready for. They may get unwarranted attention from people because they look older. Right. And there's even potential concern for abuse, sexual abuse.
Right.
So those are usually the parental concerns for why they bring the child in.
All right, if you were a parent with a child with precocious puberty, what are you going to be worried about?
Right. Yeah, you know better than me. Do you drink coffee now? No. Coffee? Like this. You can find on Home Depot.
What are you going to be worried about if your kid has precocious puberty? I'd have quite a bit of worries. I think they're too young to wrap their heads around having a period or having issues, and with society, it can get kind of dicey, right? Just keep it in mind.
The other concern they have is often, what am I doing wrong? There are a lot of questions about, should I have fed my child organic food? What about the soap I was using? What about the soap operas my child was watching? They're really concerned about something they might have done. And they worry about these additives in our plastics, in our teeth sealants, etc. They worry about evils in our environment.
Okay. So things that you address in the visit that you have with them are definitely some of the concerns that parents inevitably have about what they could have done differently.
Exactly. We start out assessing in a sort of a systematic way. The first question we want to know is, when did this all start? And what did they notice? And it's really important to break down the signs of puberty because different hormones contribute to the different signs. For example, in a girl, if she's presenting with some body odor, some acne, and some pubic hair, but no signs of any breast development, that leads us down the road to worry about what we call her androgens, or her male hormones.
She acted like she was gonna come and rub on me for a
I
minute.
know.
I don't know you.
Right.
If a girl comes in with just breast development, but none of the body hair or body odor, we think, aha, she's been exposed to estrogens.
Oh.
And so we get a lot from the physical exam in terms of thinking what hormones to go after.
Okay, so even though the definitions of precocious are just any of these, different phases of development happening too soon, the combination that you see is going to direct what you think is going on with them clinically.
Exactly.
Okay.
It'll make us more or less worried, and it will take us down one avenue or another thinking about what could be wrong, what level of abnormality in the hormone system is at work.
Okay. Can I ask a question? Just curious. So what are the most common diagnoses that you give to people coming in with their kids that are concerned for precocious puberty?
The most common diagnoses are variations on normal. There is a condition called isolated premature adrenarche, which is a fancy doctor way of saying the adrenal glands producing their hormones. We see pubic hair, underarm hair, and acne.
Do you guys know what this is? It is flusterity.
We also can see isolated breast development in little toddler girls. That's not concerning.
So that would just go away? Or?
Yeah, typically that begins between 6 months and 2 years and goes away.
Okay.
But even within the more full-blown cases where we're seeing the breasts and the pubic hair in the girl, or the enlargement of the testes and the pubic hair in the boy, where it's full-on, full-blown puberty, it may be idiopathic or not pathological. We think that in girls who develop fully, 95% of the time, even if they have the full puberty, it's idiopathic or not pathological. Whereas in boys, about 50% of the time, there is pathology. So the condition is less common in boys, but when it occurs in boys, it's more worrisome.
Oh, interesting. Okay. So it's less common for boys to have any signs of precocious puberty, but when it does happen, you worry more.
Exactly.
Okay, so boys are less likely to experience precocious puberty, but have a much higher risk for it to be really something pathologic, like cancer. That's how we usually catch that, like testicular cancer in boys, is when they start precocious puberty way, way, way earlier than they're supposed to be. It starts secreting at an abnormal time.
Exactly.
But it's very
more
rare.
likely to be something bad.
Exactly.
Okay. So I'm guessing as a endocrinologist, once you've sort of ruled out the normal things, then you start thinking more about sort of what's going on in terms of all the different hormones that are controlling these things, which maybe is something that we'll talk about in a different lecture.
Exactly.
Is there any other sort of general things that you wanted to address when just talking about?
I think the general advice I would give to a parent, if they see signs of puberty in their child, before 8 in a girl, before 9 in a boy, they should at least question their pediatrician about it, and the pediatrician should do a complete exam. And the other factor that needs to be looked at carefully is growth, because a child who's truly in puberty will have a growth spurt. So those are things that parents can be aware of at home, and I think it's important that the parent ask the pediatrician about it if they're concerned.
I'm going to go back.
Of at home, and I think.
Okay. So, precocious puberty is not a particularly complicated thing. We don't really talk about like under puberty or if it's like too late, because it does eventually come. Precocious puberty is an issue. It can be a pathologic issue. Our purpose here is to understand what it looks like. Puberty should start around 10 or 11 in boys, 10 in girls, 11 in boys. It's a little later, so their growth spurts are a little later. But when we're looking at 8 or less or 9 or less in boys, we have a problem. For our intents and purposes, we have to know what kind of evaluation they're going to end up getting, and if it's a normal variation in the family, if they typically start early. So we have to have family history here. We can't just base it off of what this child is experiencing at the moment in time. Then they can go to an endocrinologist for further evaluation. Now, in boys, there really isn't a lot that we typically do, because it's typically more than likely a pathologic thing. So if it's a tumor because they're over secreting, we remove that tumor or cancer, and it's over and done with. If that's the issue. We can also do something else. If it's not a cancer issue, if it's not a tumor issue, and they're having precocious puberty, what do you think the treatment is to stop the hormone from secreting? What do you think we do for treatment for this particular issue? What do we already do to prevent people from getting pregnant? Anybody know? Anybody know the treatment for precocious puberty? On my sheet. Treatment for precocious puberty is birth control. So first we have to make sure it's not a tumor. All right. So we're going to do some imaging. But therapy for females is birth control. We put them on this. They don't have periods. It's a certain type of birth control. It's not like one that's over the counter. Depends on what hormone is being over secreted. But irregardless, what we need to know about it is that it's birth control. And when they get to the age that their mother started her period or puberty, we take them off the birth control. And then puberty starts back on track. So say they started puberty at age 6. Very unusual. Don't need a little girl starting puberty at age 6 at all, no matter what it is. And so we put that client on birth control. And we stop this particular problem. They go on, have a normal time in childhood. And then if mom has her puberty typically starting for mom at age 11, then at age 11, we take the little girl off of birth control and everything just kicks right back in and like nothing happened. And puberty started at a normal time. And that's it. Okay? As long as there's nothing else pathological that's happening. Got it? Does that make sense? Don't overcomplicate this. All right. So that's our particular nursing consideration. All right. So the next piece here I put here is diabetes insipidus and SIADH. I'm not going to talk about it because these are exactly the same as an adult. I only put it here so you can read it and review it. That you are reminded that diabetes insipidus and SIADH is still something that you should know and look at and remember from MedSurg, but there's nothing special pediatric-wise for either of these. It can happen in pediatrics, absolutely, especially when they have brain injuries, or kidney injuries or strokes. Those particular pieces that can cause SIADH and DI can happen in pediatrics. But the treatment plan and what they look like and how all the symptomology manifests are exactly the same as an adult. I'm going to leave this here. And the next piece we're going to talk about is congenital hypothyroidism, which we'll do after this commercial break. Okay, so it's 10:10. Let's take a quick break, 10 minutes. Come back at 10:20, and then we'll go on to something pretty unique. Congenital hypothyroidism is not like, they're born with it, so it's different than like adult hypothyroidism. welcome back. Here we go. Congenital hypothyroidism. It's how it sounds. They are born with hypothyroidism and will have particular issues. What is hypothyroidism? It is low T3, T4, and a high TSH. And how they can develop this in utero is it could be a maternal iodine deficiency, or there's a developmental defect in the thyroid gland. Okay. Clinical manifestations are very similar to adults in the sense that they have this weight gain and they're puffy, but their weight gain is edema, okay? And they have a very high risk, or they have jaundice. They're tired. And because of that they're fatigued from hypothyroidism, they have poor feeding and therefore slow or poor growth and can be failure to thrive. Now, yes, you're like, well, failure to thrive is weight loss and not growing, like lengthwise, head circumference-wise. True, but they can also retain water, so they're going to gain bad weight, kind of like heart defects. They also gain a weight, an edema type weight, and that is not good for them. And they also have failure to thrive. Very similar in that sense. These babies, congenital hypothyroidism, have poor muscle tone. They have a low or hoarse cry. Their cry is different. They're hypothermic, so they have a low body temp. And their eyes and tongue are swollen. And it is distinctively swollen. I'll show you a picture in a minute. They also are one type of baby disease that has a lack of meconium stool within the first 24 to 48 hours. Now, we've talked about other ones. I told you to make a note of this. The first one that we talked about was cystic fibrosis. The second one was Hirschsprung's disease. This is your third one. Congenital hypothyroidism causes a lack of meconium stool within the first 24 to 48 hours. There is one more, and I will tell you what that is now because it's not in any of the other, it's not something that we typically learn here. And number 4 would be imperforate anus, where there is no hole. So that's an actual physiologic issue that was easily solved with surgery. They usually don't have a lot of problems, but clearly if there is no hole where the anus is, they're not going to poop. So there's, again, that one has a lack of meconium stool. This one, the third one, has a lack of meconium stool because of the slowed metabolism of these babies. They're fatigued, they're tired, they have low muscle tone, and hence they have this slowed metabolism. Just like an adult with hypothyroidism has a constipation issue, similar to babies, but it shows up as a lack of meconium stool. If untreated, this is the worst part. Oh, hold on, before that. They also have a inguinal hernia. All right. An inguinal hernia is where they have a herniation at the umbilicus, at the belly button, and their intestines can squeeze out of that out of that hole, and so that was an inguinal hernia. Wait, no, that's a umbilical hernia. I'm sorry, inguinal hernia is the other hernia. It's in the inguinal canal. Sorry, it's in the abdomen. They have an inguinal hernia. They have an umbilical hernia? Yeah, sometimes. But the other really, 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 really important thing about this is if untreated, they will have a permanent intellectual disability. The longer it's untreated, the more damage it causes to intellect. It is terrible. Okay. So what does this actually look like in an infant? It looks like this. Oops, I didn't mean to click that. Well, they have, this baby is jaundiced, but this is what he looks like. He has macroglossia, which is the swollen tongue and lips right here. He's mottled, which is right there. And it's called a mixed edematous face. So it's, look in the word right here, edema. So edematous, they have a face that's very puffy and round. Let me go back one. So this picture is a baby that was born, and also very thick, coarse hair. They have a lot of hair for some reason. Swollen lips, swollen tongue, very swollen cheeks. Their eyes sometimes are so swollen they're shut. Now in B, this is the same baby a month later that is on medications, and the tongue has reduced in swelling. Their eyes are much more like less puffy. Eyes are much bigger. This is from edema right here. And you can see the puffiness in the face has reduced. You're like, well, it's a month older. No, this is what this baby should have looked like when it was born. They are born with their tongue sticking out. There's a lot to that. There's another really famous picture. Where's that little girl? Like this one also has the swollen tongue and lips. There's a before and after picture of a little Peruvian girl. She's like super famous. She's actually in the textbook. I can find her. She usually shows up. Oh, here she is. This is another good picture. So at 11, she was in this remote village. It's in the book. I learned about her from somewhere. And she has untreated hypothyroidism, congenital hypothyroidism, the swollen lips, the swollen tongue. Her eyes are puffy here. Cheeks are puffier. Her hair is very coarse, like real rough, real brittle hair. After a couple years of treatment, as you can see, her lips are reduced in swelling. Her face has reduced in swelling. Her eyes are actually much wider than it used to be. And her hair has like thinned out and softened, and it's definitely less coarse. So these, don't look at that baby. That's a big ass goiter. They can also develop a goiter, but it's harder to, this is a very severe version. Please don't look at that. This is more subtle. And that's what we typically see in these kids. We usually try to catch it as early as possible. So diagnostic tools to treat this. So this baby's going to come in and you're only going to see these clinical manifestations. And you're like, well, what is the problem? We can't measure intellect at when they're born. We can't. We just know this is a thing if we don't treat this soon enough. These babies are going to be born with this like puffiness, and they have jaundice, and they don't feed well, and they have a hernia, and all these things going on. They look a little syndrome-y, and is it a genetic syndrome? So we're going to run diagnostic tools. And most importantly, when they're born, we run a newborn screen, which carries about up to 25 to 30 different congenital diseases. And one of them we catch real early in the United States is congenital hypothyroidism. But it doesn't mean you can't not know what it is, because we do it's a very global world, and we have a lot of immigrants and migrants, and we can see these kids, if uncaught, we catch this a little later on. Now, what other diagnostic tools, of course, we're going to have is checking the hormone levels themselves. We're going to look at the TSH and the T3, T4 levels. They're going to be abnormal. The newborn screen is going to tell us if they have congenital hyperthyroidism, and a thyroid scan is going to be necessary for this. Okay. Therapy is just like adults. We're going to give levothyroxine. No more, no less. And to remember what levothyroxine has some special things to it. These medications are given 30 minutes before a meal or 2 hours after a meal, and typically first thing in the morning on an empty stomach. This is forever. they have lifelong treatment. Cannot get off of this. But what's unique to pediatrics is that children grow. And as children grow, as you know, we calculate how much medications we give them by weight. So we have to check their thyroid levels every 6 months, and we alter the dosage according to as they grow and their levels of thyroid hormone in their body. Okay. And of course, we have to remember, do not give levothyroxine with iron. And this is extremely important because these children, all kids need iron. All kids. It is one of the supplements that we give, just like we give vitamin D. All kids should get vitamin D. Everybody should be taking vitamin D. But to remember that levothyroxine cannot be given with iron. Please remember that. So, in general, congenital hypothyroidism is not a crazy concept. It's very similar to being, adults, but these kids are born with it, and so therefore they can't tell you certain things. And so they will clinically manifest in this sense. What the biggest difference or issue with this is that if untreated, permanent intellectual disability, which is, we don't ever want that for children, ever. Hyperthyroidism I left blank because it is just like adults. So you can fill that in as a review on your own time. It's exactly the same as an adult, but I put it here because you're going to need to understand it. There may be questions on it. All right, so it's a good thing to review. It's in your EDAPS also. Fill it in. I only have so much time today, and we still have stuff to do. Go make sure to review your thyroid storm. And also here, review hypoparathyroidism and hyperparathyroidism, exactly the same in children. Nobody's born with this congenitally. It just manifests similarly to adults, except kids. And I put this nursing alert on here on purpose. The Chavostic signs for Sosine and Tetany, very important to remember and to review. Here's adrenal cortical insufficiency, exactly the same as adult. Up to you if you want to fill that in. And we're going to move to something that's also congenital. So every time you see the word congenital, this is pediatrics. They're born with. And when they're born with and they show up with it, we got problems. All right. This one's pretty unique. It's pretty different. Congenital adrenal hyperplasia is a low cortisol, low aldosterone, and high androgen. All right, I highlighted androgen because it has some unique aspects to androgen. Precocious puberty, of course, when you're talking about aldosterone and androgens, there is a precocious puberty element to this. When we discuss precocious puberty, it's just precocious puberty. If they have congenital adrenal hyperplasia, you're just gonna add precocious puberty as one of the signs and symptoms now of this particular issue, plus a few other things. All right. What causes congenital adrenal hyperplasia in children? It's genetic. It's a 21 hydroxylase deficiency. Okay, it's not a sex-linked genetic. It's not that. It is 100% in the chrome. It's a genetic issue. So they have this deficiency, which causes these hormones to be wonky. There's two low ones and a high one. And with that being said, it mimics the hypoaldosteronism because it has a low aldosterone. But I put here the most important thing, the biggest differences between the two. So in males, we have early onset puberty because they have this like early high androgen secretion. And so they have early precocious puberty. They have a fast body growth and they have premature completion of growth plates. And so they lead to short stature. That's the unique piece of males. For females, they have this very unique thing called ambiguous genitalia, which is a masculinization of the newborn. They are inside, have internal female reproductive organs. They have ovary, they have a uterus, they have a vagina, they have that. But what happens is the clitoris masculinizes, and it could be a severe masculinization that it literally will look like a penis, or it'll be a very ambiguous masculinization where the clitoris kind of looks like a penis. They also, when they get older, they also have a possible precocious puberty and early development that we can solve with endocrinology. I mean, this child's going to be seen, male or female, will be seen by endocrinology. But the very, very highlighted unique piece of this is the ambiguous genitalia, and that's our problem in nursing. That's what we have to help the parents through. And we'll get there in a second. Diagnostics-wise, we know that this could be a potential problem, so therefore it is one of the diseases we look for on a newborn screen, one of the 25 to 30. And also a diagnostic tool for this particular baby is genetic testing for gender confirmation, because they will look like male babies, unfortunately. Can it be repaired? Yes, but that's also part of our therapeutic communication with the parent. How do, therapy-wise, it is simple as replacing the deficient hormones, the low cortisol and the low aldosterone levels. We can't really do much about the androgens. Really, we can't. So they're going to have this particular issue. So nursing consideration-wise, which is what makes it unique, is ensuring that the parents or caregivers to love and care for the baby. This is extremely important. Okay? Extremely, extremely important. And also to maybe wait for naming the child until gender and genetic testing is confirmed about gender confirmation, if they so choose that. I know that the society today is much more accepting of gender problems, or not problems, but gender changes. But they just had a baby they thought was male. And it is now they're being told that it's potentially a female baby, but we're not sure until gender confirmation comes back. And on a newborn screen, not only that, but they also have congenital adrenal hyperplasia, which has low cortisol and low aldosterone problems. Those are problems in itself, right? So make sure to understand that part of it also. But what's super unique to this, super unique to nursing, is that how to help the parents work through their feelings on this particular baby. And most importantly, as nurses, we have to ensure that the caregivers love and care for this baby. It is not a requirement. It is not a requirement. But the genetic testing will come with, they can, I think it automatically comes as a part of, we have to understand, is this a 21 hydroxylase deficiency? And that is a part of genetic testing too. And they can choose to not know what the gender of their baby is. I mean, there is absolutely people out there that are gender neutral and will not want to know, and that's okay. But think about when this child goes into puberty, to be prepared for that particular aspect. Just think about like what could be our future situation, and understanding that they actually should know the gender of their child, because if they continue on as this is a male child and all of a sudden at 11 or 12 they start breast development and they have their menses, but we're going to have a whole slew, a can of worms that are going to be opened early, right? Opened later, and that's going to be a huge problem. So I can just see future future problems along the way. So my education to the parent is, know what the gender of your child is. Especially if it's female with ambiguous genitalia, they can be corrected, and so like surgically corrected to look and be more female, and that's a whole nother issue with parent. That's the family's decision. But not telling the child that this is a problem or not wanting to know is avoiding the particular issue that's going to come down the line in 10 years or 13 years. You see what I mean? There, because you don't want a boy to be treated like a boy this whole time and all of a sudden have a period. Like, I think they would freak out a little bit, just slightly. And oh, by the way, the penis isn't going to work because it's not a penis, it's a clitoris. So we still have to have genetic gender testing overall. Okay. Whew. Does that make better sense? I hope. Is that more palatable? Okay. So us as nurses have to like really encourage them to not encourage that this is going to happen. This has got to happen because there are a lot of future problems that could happen, right? Woo. UTIs, not just mentally, but physically. There's going to be, we can't avoid the problems. There's no avoiding this. And we still have to treat the baby for the low cortisol and the low aldosterone problems. So besides the mental issues, the physiologic issues. Okay. So we can do surgery for corrections, which is optional and up to the specialist and the parents, but typically it is a thing. And it is the hypoaldosteronism is a lifelong problem. So they also need to take medications lifelong for the low cortisol and the low aldosterone issues. Hyperaldosteronism here on this side is only an adult issue, really. So not particularly a concern for me. But the congenital adrenal hyperplasia is a problem. And a pediatric problem. Okay. Is there something else I wanted to play today? Hold on. I'll put some videos down here. Okay. So we're going to get into... Well, before we get into this, I just sent an email out to my group about the Children's Hospital. Can somebody check you got the email for where to drive to at Children's? I think it's like Brooke, Nipur, Elise. For those that are going, yeah, be there at 8 so we can just get started so we're not missing too much time. Please meet me at 8 o'clock so we can just talk about our day. And if we get lost, maybe we can get our badges a little early so we can wander back over to the children's side. Can we meet at 8 o'clock? It's still a little later. Because there's like parking. It's a really big campus. Like, it's huge. That's all. But that's fine. Meet at 8 o'clock. And do not park in the street. There was a couple people that parked in the street last time and they got like $300 tickets. Don't do it. Just park in the Kresge lot and bring the ticket over. Just walk over. All right. The thing. I don't want anybody to get a ticket. I don't want to get their cars towed. Don't do it. Don't think you can get away with it. You're short receiving, and that those police officers on the DMC campus are no joke. They will tow your car. They don't care. Okay. And then we'll walk through the tunnel, get over to Children's. All right, thanks. All right, so let's do a quick video. Let's break this up a little bit. I want this.
Have you ever had a delicious meal only to feel super bloated afterward? Let me fill you in on my secret to zero bloating that doesn't...
HHNS.
Good for her. All right, so for pediatrics, when we're talking about diabetes, it is type 1 diabetes. It is, although type 2 diabetes is now becoming a younger and younger childhood issue, it is not what we're worried about here. We are worried about type 1 diabetes. And typically when we catch and patients develop type 1 diabetes, they come in an emergency. That's usually when we find it. And they're in DKA, diabetic ketoacidosis. So I have this video, we're gonna watch it for a second, as a reminder between the difference between diabetic ketoacidosis and HHNS, which is a type 2 diabetes problem, okay? There's differences between the two. So this is just, part of it's new, I hope, or maybe you've already know a bit about DKA. And then HHNS is a type 2 diabetes issue. Look, HHNS, old guy, and then this kid with diabetes. How long is this one? 13 minutes. So let's, it'll be fine. We'll play this and we'll take a little break.
Breaking down the differences so it finally makes sense. Now for my Simple Nursing members, be sure to grab this study guide to follow along. By the end of this, these two conditions will be crystal clear and stuck in your brain, ready for test day. All right, let's jump in.
So how do you tell the difference between DKA and HHNS? Well, DKA is more common in type 1 diabetes and HHNS for type 2. So think which letter comes first in the alphabet. Well, guys, D comes first, so it's type 1, and H comes second, so that's how you know it's type 2. Now, what is DKA? Well, guys, let the name help you. Diabetic ketoacidosis. There is no insulin produced since it's type 1, guys. We have none. The body killed its own pancreas, and as usual, no insulin means no sugar in the cell. Therefore, the body must burn fat for fuel, resulting in fat waste, and ketone bodies are produced. Kind of like how a diesel engine blows off a lot of exhaust, ketone bodies are very acidic wastes. So we have high acid in DKA, or diabetic ketoacidosis. Now type 2, we have few insulins barely working, so HHNS or just HHS, let the name help you. So hyperglycemic, we have the higher sugar. Hyperosmolar, we have very thick dehydrated blood. Guys, huge dehydration here. And non-ketonic, we have no ketones, and S is for syndrome. Now, since the body has barely enough insulin to put sugar into the cell, well, the body burns sugar for fuel, so we don't get those ketone bodies. So guys, think type 2, you have a few insulins working, so no fat burn, no ketones, since the body's burning glucose. Now, typically, DKA has a faster onset, and consequently, it's easier to fix, since the patients are young with type 1 diabetes. And HHNS is a slower onset with older patients. So guys, it's harder to fix HHNS. Now for the causes, DKA, remember the 3 S's like high sugar. So sepsis, like infection, guys, always an NCLEX favorite. The number 1 cause of DKA is infection. Second S is for stress like surgeries or even skipping insulin. Guys, kids in type 1 will get the flu or an infection and then boom, end up in DKA. Or they'll go to surgery without increasing their insulin dose and then bam, DKA. And similarly, on the other side, older patients in HHNS commonly caused by illness and infections. So what are the main differences in the signs and symptoms? Well, for DKA, this is super hard, right? Just remember the acronym DKA. So D for a dried body, guys, and high sugar. 250 to 500 from the lack of insulin. Guys, that's a huge key word. 250 to 500 with type 1 diabetics. Now, K is for ketones and Kussmaul respirations, or known as fruity breath. Keywords here for the NCLEX. Deep, rapid breathing that smells fruity. This is called Kussmaul respirations. So think ketone respirations.
Who's coming in the driveway?
So we say, ketones, do you love me? Are you riding? The body is in metabolic acidosis. So the body tries to correct itself, or basically compensate, and get rid of all this acid. It does it by panting like a dog to breathe out all that carbon dioxide, which we call carbon diacid. So remember, we'll see Kussmaul respirations as deep, rapid breathing as the body tries to get rid of all this acid. And the memory trick here is carbon diacid. Now next, our A is for abdominal pain, which is a huge NCLEX tip. HHNS does not have abdominal pain, only DKA, typically on the NCLEX. And our last A is for acidosis, metabolic acidosis, guys. Huge NCLEX key number here. Write this down. pH 7.35 or less. Huge number on the NCLEX. It will always show up on SATA questions. Now switching over to type 2, the slower and more serious one, since it's harder to fix. So HHNS, guys, remember the triple H's here. We have higher sugar loss with higher fluid loss. So sugar over 600 plus and extreme dehydration. And our third H is for head change. Now the NCLEX term is neurological manifestations. Guys, write that down. We'll often see confusion with classic signs of HHNS. Guys, we don't get head change or neurological manifestations with DKA. Our next N is for no abdominal pain, guys. DKA, we have that abdominal pain. As well as no ketone. So this means no acid, no Kussmaul respirations, basically meaning no fruity breath and no deep, rapid breathing. Now that's probably the biggest difference than DKA. And lastly, S is for our slower onset with stable potassium, 3.5 to 5.0. So when you get an NCLEX question stating high sugars with neurological changes or neurostatus changes, guys, with no acid, definitely HHNS. And if you get a question about a diabetic kid with abdominal pain and that pH less than 7.35, guys, it's most definitely DKA.
Want more insider tips and tricks for NCLEX style questions? Well, our Simple Nursing membership has exit prep lectures and thousands of questions covering every nursing school and NCLEX topic.
So for DKA treatments, simply remember the acronym DKA. D for dehydration. Guys, we treat the dry first. Keyword is 0.9% normal saline. Now, I got a lot of questions on this from our NCLEX review, so please write this down. Your first priority action for both DKA and HHS is fluids. And the correct answer is always normal saline. Now, K is to kill the sugar slowly, guys, to prevent that low sugar. So we do keyword here, hourly blood sugar checks. Write that down. We want a slow sugar drop. Sugar is really way high, kind of like a plane. So guys, we want to land that plane slowly, not too fast, since we don't want to crash our patients here. The main goal here is to prevent that low blood sugar, that hypoglycemia, that 70 or less. So a slow sugar landing is the goal. So basically, as sugar lowers, then the insulin lowers. We just titrate or adjust the insulin drip and lower them together. Typically, any sugar over 250, we give IV insulin. Now, key term here, regular insulin only. So remember, regular insulin is ready to go IV. And we start with the bolus first, basically meaning rapid infusion. Now, caution, tests will try and trick you guys. Only regular insulin is put right in the vein. Not NPH, not Aspart, not Lispro. No one else here gets the VIP pass. Remember, only regular insulin is right in the vein or ready to go IV. Now, when sugars drop below 200 or when, keyword, write this down, ketones resolve. This means the body is now burning glucose for fuel and not fat anymore. So we switch the patient from IV insulin to sub-Q and then add some dextrose sugar to the IV bag, typically D5W. Now you're probably asking, why do we add sugar if the sugar's already high? Well, guys, it's kind of like landing that plane. Sugar is our landing gear. We want a smooth and slow landing, preventing that low sugar crash of hypoglycemia. Now, a common test question is always a question about a child in DKA who's too nauseous to eat or maybe vomiting. And the question always says, do you still give him insulin if he doesn't have food? So think about it here, guys. Well, yeah, you still give the kid insulin, guys. His sugar's really, really high. Big NCLEX tip. Still give insulin on those sick days. Lastly, we add the potassium. Key word here, write this down. During IV insulin, not after. During. Big NCLEX tip. And yes, even when potassium is normal between 3.5 and 5.0. Now you're probably asking yourself why. Well, guys, remember, insulin puts sugar and potassium into the cell. So naturally, both sugar and potassium drop together. So to prevent a potassium crash, we add potassium, sort of like how we add sugar. Now, a little side note about potassium. Think potassium pumps the heart. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys, per hour, a full 60 minutes.
He said mLs, and it's not even milligrams. It's potassium comes in micrograms, MEQs. Doesn't come in micrograms. It comes in milliequivalents. I'm so sorry. It comes in milliequivalents. So even if it's going IV, potassium should on a unit go, like on a regular med-surg unit, should only go like 10 to 20 milliequivalents per hour. So when you look at an IV bag and it already has potassium in it, it typically only has like 40 milliequivalents in the whole bag. So if there's 40 milliequivalents in the whole bag, it's a 1,000 liter. Oh, there's so much mathing. Hold on. There's 1,000 liters in the bag. You're not giving that much potassium per hour. You're probably giving like 3 or 4 milliequivalents of potassium per hour, which is fine because it's a very gentle potassium. Sometimes they have to take we have potassium bags and stuff like that, but it's a very specific thing. There should be hospital policy on how much potassium you're limited on giving at any one time per hour, because at a certain point, if you're giving that much potassium and they're losing potassium or there's something wrong with potassium, they should be going to the ICU. At certain points, when you as a nurse on a med-surg floor or on any regular floor is playing with the potassium and you can't keep, like you're playing catch up with potassium or the potassium's too high, they should be in ICU because their heart's gonna stop somehow. It's gonna mess with the heart pumping and the cardiac, all the cardiac stuff. So potassium we have to be very, very careful with. And he's right with the potassium and the insulin and sugar. When we have potassium problems, like potassiums are too high in a patient that has like a renal issue, we can do insulin and dextrose. Even though they don't have type 1 or type 2 diabetes, that's not the point. The point was to push the potassium back into cells. And so we'll do that kind of thing. In this instance, the sugar is the problem. So if we start doing that, it messes with the potassium in the body. That might already have been okay, or we're already losing potassium somewhere. So always understand the path, though, of what is happening and what is cascading down. Are we having the potassium issue and we have to cascade this way? Or do we have a diabetes issue with a sugar issue? And then how is that messing with the potassium? Okay, so that's a part of patho.
Minutes or more, usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys. It's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common. Now, to help you remember the ECG rhythms with high versus low potassium, our memory trick is very simple here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5 point.
So why at clinical on Saturday, I was again irritated because that 18-year-old child, well, he's man-child, with anoxic or with a brain injury with increased intracranial pressure, they did not have him on a CR monitor. And so nobody could see his rhythm. Now, granted, I'm not expecting a potassium issue in him, but I would never be able to catch it either because all he was on was a pulse oximeter. So as you can hear from me, that if you're going to be in the hospital and you're basically intermediate care, why is certain people not monitored as much as they should be, like him?
No. And the exact opposite for low potassium below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now for HHS treatments, guys, remember the acronym HS. We always treat the hydration first. Both DKA and HHS, hydration first. 0.9% normal saline. Huge NCLEX tip, guys. Now, we can always do hypotonic fluids, but that's not as common on the NCLEX. And then S for stabilize the sugar with insulin. Again, caution, guys, only regular insulin is ready to go IV. Big NCLEX tip right there again. And just like DKA, we correct the sugars slowly with key term hourly blood sugar checks and insulin going from IV bolus to subcutaneous injections. We land that sugar slow. Now, as far as potassium for HHS, out of 10,000 questions we took while making the script, the potassium only came with DKA. So guys, remember, adding potassium for DKA. But a lot of questions came up about reassessing the hydration status. So write this down, guys. So we reassess both blood sugar and rehydration status.
Hydration is extremely important in both of them. When you get NCLEX questions, or you get questions, especially with DKA. DKA is one of the most tested topics for on the NCLEX or in here. DKA is it. The second one, that's high sugars. The other one, I'll give you a hint, is hypoglycemia, or we'll talk about that in a minute. But for DKA, which is hyperglycemia, always start with airway breathing and circulation, okay? If their sugar is too high, they go into a DKA coma. And if they go into a coma, we have a breathing problem. Okay, so always start with ABCs. Always go back to your test-taking strategy number 1, ABC, even with DKA or HHN. The potassium is a problem. And guess what? There's a K in DKA. Potassium is a K. So please remember that we have potassium problems and potassium cautions in DKA. It's a big, big deal. But ABCs, circulation, airway breathing, circulation. Circulation is always about hydration. And if we give them a 0.9 saline bolus, that's the first thing we want to do, it does help dilute the blood because they have literally corn syrup running through their bloodstream, and it is thick because the sugar is so high. Like, it's straight up corn syrup. That's thick. We need to dilute that to bring some of the sugar down before we even start with, we're going to do a blood check. Of course, that's an evaluative part. But we got to bring the sugar down, and one of the first ways is to hydrate and dilute them. Because they're going to be dehydrated automatically. They're dehydrated. It is what it is.
So for hydration, we'll see stable blood pressure, cap refill 3 seconds or less. And guys, skin, write this down, should not be pale or cold. It should be warm and have some color. Urine output should be 30 mLs per hour or more with normal specific gravity. Too high and the body is dry. So the little memory trick here is hemoconcentration is an indication of dehydration, basically meaning high and dry lab values, very heavy urine. And hemodilution is overhydration, low liquidy labs with low liquidy urine. Lastly, don't let the NCLEX trick you. Rehydration status does not include apical pulse, lung sounds, or even pupil assessment. Thanks for watching. Did you know you can
All right, so great video, great review. Somebody different to yap at you. This video's link is in the master sheet towards the bottom. Here, it's right here. And so it's a great review with also like helps with acronyms, tips and hints. Can't do better than that. All right, let's take a quick break. 10 minutes. And I need to go to the restroom. So I'll be back in 10 minutes. We'll be back at 11:17, finish up with diabetes type 1 and especially talking about like hypoglycemia and hypoglycemic issues.